Well, thank you. I think as let Karen come to the stage, and let's thanks Vilma one more time for her effort on this. And then Karen will be giving us a bit of a journey to Zambia and some partnerships that are happening through Chaz. So welcome, Karen.
Thank you very much. Good morning. Good morning. I'm saying good morning because it is good morning at home. We are 6 hours behind Washington time. Um, but I'm very happy to be here representing the Church in Health, a silent health service provider, silent for over 100 years. Because in our region, we know that it was the first missionaries, it was the missionaries first that introduced any form of health care. And for many years, churches haven't been recognized. It wasn't until the PEPFAR program, by the way, that deliberately targeted implementing the PEPFAR programs, particularly in our region, and it was targeting 15 countries. But in our region, it targeted working within the church health services. And until that time, we were not actually recognized as major health providers. I'm very happy to be here, not just to represent the church in Zambia in health service delivery, but also in ACHAP, which is an association of church health networks in Africa. So I think my presentation will just highlight a little bit about health service in Zambia. But what I want to emphasize on very much is the partnership that exists between the Churches Health Association of Zambia, or the Church in Health, and the government of the Republic of Zambia. Which one do I press? Right. This one?
Yeah, right there.
Okay. I just wanted to give you a brief, just an introduction of Zambia. Zambia is a large country, about 752 thousand kilometers, but only a population of 14 million people. But what is very interesting about our map and our location, geographical location, is that we are landlocked and we are surrounded by 8 countries. What it means in terms of public health and disease control, if there's any epidemic happening in any of those 8 countries, it means that Zambia, by default, it is affected. So all our border areas, if all the 8 countries had some form of epidemic, even though we may be okay, we would be affected. So that's very peculiar. So we are surrounded by 8 countries. And even during the struggle for independence, it meant that for Southern Africa, we were accommodating most refugees in our country. The Zambia Health System Strategy, that is our policy vision, a nation of healthy and productive people. The key principles are primary health care, that we would deliver this through the primary health care approach, equity of access, that it will be affordable, cost effectiveness, accountability, partnerships, decentralization, and leadership. The main emphasis have been on universal coverage, equity of access, quality health care as close to the family as possible. Those are some of the selected indicators. You can read for yourself because I'm aware of time. But most of our people really do live below the poverty line. We have set a target for ourselves where we want to reduce that by next year, God willing, that we will reduce to 29. The GDP per capita is, we have improved over the last 10 years, but we could do better. Our mainstay of economy is copper, and even wealth in Zambia, like most developing countries, very unevenly distributed. So you get a few people who are really enjoying the wealth, and the majority of the Zambian people really living below the poverty line. Our health indicators could also do much better. Malaria is endemic in most parts of our provinces and districts in Zambia, and claiming a lot of lives, particularly in the under 5s and the pregnant women. and old people, and also people living with HIV and AIDS. Those are the indicators. But HIV and AIDS, I cannot leave this slide without mentioning. We were in the epicenter of HIV and AIDS epidemic in the 90s and early 2000. I think we have reduced the prevalence rate, which used to be about 22% in the 90s, to about 13%, which is, I think a big achievement, but thanks to programs like PEPFAR and the Global Fund and other cooperating partners. Our under 5 mortality rates, the 1,000 children, I think still leaves much to be desired, and so is the maternal mortality ratio. I think we have made some progress, but we still do better. The key determinant of health for Zambia is, I think, like most developing countries, is just poor environment. The Ministry of Health estimates that about 80% of the conditions that are presented at our rural health centers and hospitals is mainly due to poor environment, poor water, or lack of access of water, poor sanitation, and environmental conditions like food safety, housing, and amenities, and climate change. I think Zambia, for a long time, we've not been prepared for climate change. So sometimes we get very heavy rainfall, and we're actually very unprepared. And this is actually operated in the office of the Vice President. So we get cooperating partners helping us year after year. And sometimes I wonder whether we're going to graduate from that. So, but we're very, very unprepared. Malnutrition, again, I think most of our children are stunted, and malnutrition, not just in elderly people, but also in under 5, as you can see. Occupational health, is responsible for a lot of disability, morbidity, and mortality, also a major problem in Zambia. And occupational health related affect productivity, as we are aware. Public-private partnership, PP defined, this is the way I understand it. I understand it to mean that it's a partnership which involves the private sector in the health service delivery, but with the government of Zambia providing an enabling environment, whether we like it or not. In our region and in most developing countries, unless the governments of the day is well and willing to embrace partnership, none of that is going to happen. But I think for us in Zambia, we've been very lucky that our government, since the independence, has embraced partnership. Zambia PP in the context, I think we know that public health system, particularly in low, middle-income countries such as Zambia, face significant capacity and resource limitation to address health service-related challenges on their own. Zambia has embraced partnership since independence. So when I hear public-private partnership, I wonder, because I mean I was a little girl. I think I hadn't started going to school yet, but there was always partnership with the mining industry, which established a lot of hospitals on the Copper Belt. In fact, we had 10 hospitals right before independence and even after independence. Partnership with the church. So when Zambia became independent, there was a church that provided health service, and government saw it fit then in 1994 after independence to embrace this partnership. So partnership for us has been there, except maybe the terminology was different, but it's always been there. So it hasn't been a new thing in Zambia. Private healthcare provided identify profitable undertakings, and government provides regulation to guide their operation in the interest of the Zambian people. So legislation, guidelines from the WHO that are translated at country level, and government must provide that leadership and guidance for the partners to operate. Companies donate resources as part of their corporate social responsibility. And sometimes companies in Zambia, the mines and the bank, they do not necessarily give money, but maybe they'll give blankets and medical equipment. So, they give in kind. Some of them have been able to help government extend hospitals in some of the provinces, particularly on the copper belt and the new copper mine province, the northwestern province. We have a Rumwana mine that has extended government district hospital in that area. So companies do come in to help the government. The church in Zambia, which is my main talk today, is both Catholic and Protestant churches together coming into one organization called CHAZO, Churches Health Association of Zambia, helping government to deliver health services in Zambia. The national health system, mainly the government, sometimes we get partners who think that the health system is just government. But in Zambia, it's not like that. It's the government, it's the church, which is private but non-profit. We have private also NGOs and other companies for profit, non-governmental organization mixed, but the non-governmental organization usually address diseases of public health concern, helping the government to address HIV and AIDS, malaria, and tuberculosis. We also have a large sector, and we also have a big community of members of the public who actually prefer to go to traditional healers. For some reason, they find comfort there and they are healed, and it's all in the mind, but they do go there. And so the government of Zambia has been trying to embrace the traditional healers and see how we can work with them. The role of the private sector in Zambia, for us, we see them as complementary, filling critical gaps, commercially viable gaps. So some of them are into medical diagnosis laboratories. Some of them operate air ambulances between Lusaka and Johannesburg for critical care, and also within Zambia from Lusaka, from a mission health facility somewhere near Angola or somewhere near Tanzania to Lusaka for specialized clinic. And they provide value additional services. We have some of the private providers who own eye hospitals, and this is or orthopedics hospital. This is not by the government, by the private sector. Supporting health services, commercial bank, have already alluded to that, or expanding buildings to help government, have already alluded. What has worked well for Zambia? From our experience, we think that with this partnership, public-private partnership, it has increased options for the Zambian people, service outlets and specialization. It has also helped reduce congestion at public health facilities, also strengthened efficiency and quality of services in the system, create backup options. So if one system has challenges, then the other can act as a stopgap. The PPs also pull comparative advantages. Private sector innovate, we heard this morning, and it's true, and for churches, we did innovate home-based care in Zambia for people living with HIV and AIDS. And we were able to prove and convince government that that was viable. And government in 1996 integrated that. And home-based care for people living with HIV and AIDS, although it was an innovation by the church, it became an integral component of the health system in Zambia. So I think the role of the government, in this case, the role of the government is to bring that to scale, which is what happened during the home-based care for people living with HIV and AIDS. What has not worked well? I think agreeing and ensuring fulfillment of obligations sometimes has not worked very well, because government sometimes is of opinion that a next NGO or cooperating partner will do this, and sometimes that doesn't happen because of changes, policy changes in the home country of that cooperating partner or that NGO. So sometimes things do not necessarily get done. Also, I think what has not well, there's a potential to create a moral hazard. Like I've said, government thinking a certain church will do this, and the church not ends up doing it, or this partner will end up doing it, and government thinking they will do it, and so they won't do it. So that is a moral hazard. I think the big issue for us is what has not worked well, and I think this is a message to drive home for those NGOs that come into our countries and start, health programs. is sustainability issues, not just the NGOs, not only the cooperating partners, but also the church. We've seen some church congregations that have started a facility, but 10 years down the road, 20 years down the road, they can't manage. They can't sustain staff, they can't buy medicines, they have no operational costs. So they're looking now up to government to take over. And well, government says, look, we didn't talk about this, and so we don't have money. And so people who may have been getting that service will be deprived until further notice. So that's what we've seen. We've seen major sustainability issues. So what we are encouraging is that people need to talk to government or the district health offices, that we are establishing this so that right from the beginning, government can plan along with them. So this is the partnership between government of Zambia and the case of CHAS. Like I said, missionaries established the formal health service in Zambia 100 years ago. Partnership dates back to 1994. Zambia's national health policy was a comparative advantage in the sense that at independence, Zambia says that we'll provide health services and education free of charge. So the church then took advantage of that and simply said, well, if you're going to provide free of charge, we'll help you deliver the system, but you need to pay. So this partnership is through a memorandum of understanding, and we've been an envy for most of our sister organizations in Africa, where for us in Zambia, the government deploys health workers to mission hospitals. Government provide at least 75% of the running cost to mission hospitals, and also the essential drugs government will provide. So if you talk about a sustainable organization in Zambia that works very closely with government and will be there, and it's not going anywhere because the churches are not going to give up their hospitals, it is CHAS. So we get all that help from CHAS, but they are, you know, the disadvantage of that is that health workers can be transferred anytime, and so we have chronic shortages in mission hospitals. But we cover about 50% in the rural areas and 31% of total national health care. Registered members are non-for-profit, and CHAS has performed very well, has been a principal recipient of the Global Fund for the last 11 years. And so when other principal recipients fell short in the major audit, CHAS was still standing accountable and can account for the money. That is the amount of money that we have managed in CHAS for HIV, malaria, and tuberculosis. We also are a recipient of the PEPFAR fund. That is all the mission hospitals superimposed on the Zambian map. We have 36 hospitals, 84 rural centers, clinic, and community programs. Framework for partnership, like I said, is the Memorandum of Understanding, and those are key issues in the Memorandum of Understanding, and government adheres to that. So we're very fortunate. This is what has worked well for CHAS and the government of the Republic of Zambia. The partnership has, you know, improved access of rural health, particularly in hard-to-reach areas for the people of Zambia. Government support, HR, human resource, finances, and essential medicine. What has not worked very well is government is inadequate funding. Somebody said that there's always inadequate funding, and it is true, inadequate funding. Staff transfers and infrastructure challenges, some are very old. Some of these mission hospitals are 100 years old and needing repair. In conclusion, I think for us, is PP present major opportunities for scaling up efforts in health service delivery to achieve the desired outcome through leverages of financial, technical, material, and logistics support. Thank you, and God bless.
Thank you, Karren. Do we have any clarifying questions or an initial question for Karren before we move on to the next presentation?